Great. So, hello, everybody. Welcome and thank you for joining us today. This is the fifth in our lunchtime webinar series. I'm Helen Bolton and I'm the Communications Officer at the Centre for Academic Primary Care at the University of Bristol. And in a moment, I'm going to be handing over to my colleague, Matthew Booker, who will introduce our speakers today and the outline for today's discussion. And before I do so, just a few housekeeping points. We are recording this webinar and we will share it with you after the event. During the webinar, you will be muted and your video will be off for the duration. We welcome questions and we would ask you to pop any questions you have at any point into the chat, and we'll come back to these at a Q&A session towards the end. Because our speakers today will be talking about research that is in progress, we'd be grateful if you don't share details via social media. Usually we're very up for it, but this time around we'd ask, please don't share anything via social media that you are seeing today. And that's it. I'm going to hand over to Matthew Booker now to start the proceedings.
Thank you very much, Helen, and a warm welcome to everybody joining us this afternoon for this webinar. As Helen says, my name is Matthew Booker. I'm an academic GP at the Centre for Academic Primary Care with interests in urgent care, unscheduled care, and the primary care workforce. So I'm really pleased to be welcoming you and our speakers to this session. We've got some interesting content to get through. I will introduce our speakers as we come to each of their sessions. This is the very overview outline for the next sort of 50 odd minutes that we've got together. Some really interesting pieces of work to discuss and bring to you. I'm really pleased to be joined by colleagues from the REACH collaboration. REACH is a partnership between the University of the West of England and the University of Bristol, and in particular the Centre for Academic Primary Care. We have a portfolio of research projects spanning urgent emergency care, acute primary care, and workforce issues. So this webinar today is very much in this sphere, and I'm really pleased to be joined by colleagues and some public contributors as well, who we'll be hearing from shortly to deliver this to you. And as Helen said, I'd just like to recap that for those joining us, if you have any questions, comments, or reflections at all on what's presented, then please do pop this in the chat. We will have a little bit of time for Q&A from the contributors at the end, where we will come back to those. But if you have any thoughts, please do enter them sort of as you think of them, and we can use that as an anchor to come back and discuss at the end. So before I hand over to some of my colleagues for the specific topic areas, I just wanted to spend a few moments setting the context for why we're bringing this webinar to you, why this topic of urgent care, urgent demand, same-day demand, and primary care workforce. What is the backstory to this, and why are we looking to address this question specifically? Well, here is a slide with some data from the appointments in general practice data set, which sort of presents the current picture of the amount of activity going on in general practice in terms of appointments at the moment. You'll see from the blue line, it's been reasonably consistent over the last 7 or 8 months in around about 30 million appointments per month. That's about 1 million appointments per day in England. And reasonably consistently, there's between 45 and 50% of that activity takes place on the same day. So that's on the day of request, the appointment takes place. Now, there are some caveats to this data. There are a few blips. It does include, for example, the COVID vaccinations delivered in PCN. So we do have to interpret that with a little bit of caution. But generally, the activity is around about 1 million contacts a day, and approaching half of that takes place on the same day of request. When we break that down a little bit further and look at the workforce and practitioner group, this data shows the activity for just GPs in general practice. And we see that that proportion increases even further to between half and 2/3 of all appointments are delivered on the same day in which they're requested. So that's a really substantial front-loaded component of the activity there that takes place on the same day. And of course, our challenge academically is teasing out what's going on here. How much of this is a true component of acute clinical need? how much of this is influenced by wider sociological mechanisms, and how much of it is simply down to how the system is designed in terms of access. Teasing these things apart are the key to understanding why same-day demand is so high in general practice and why there might be various solutions to that. This data shows a little bit more about what's happening and who's doing what. The graph on the left shows a typical week. It's one of the last few weeks of complete data, and how the consultations are broken down into coded consultation types. And this tells a very slightly different story. If we look at for example, acute consultations versus, along with clinical triage and along with unplanned clinical activity. So these are the three groups which are probably most representative of on-the-day true need. We see that this represents about 1/3 of overall activity. So we've already gone from over 50% of a GP's workload taking place on the same day down to coded data suggesting about 1/3 is actually same-day acute care. If we look at the right, the proportion of activity that's delivered by other professionals other than GPs and nurses, and the cream bar in particular is what we're looking at here, we see that this is really a significant component of the same-day activity is being delivered by other professionals in primary care. And this is an increasing picture and a space that we really need to pay some close attention to if this is a potential solution to some of those access and demand challenges. When we look a little bit further, this is some data where we've done some work on a large routine data set in the past to try and understand of those same-day appointments in general practice, how much of that activity is clinically same-day urgent care. And what we see here is a further different picture. And the bottom two are what I particularly want to draw your attention to, as they are really the nub of what we're trying to address here. When we look at face-to-face clinical appointments, about 1/5 of those that occur on the same day appear to be objectively clinically urgent problems. However, the amount of telephone activity, including where practices use complete telephone triage, is more than half. So we have a real challenge here of working out, because necessity is almost always a retrospective determination, we need to get enough information from patients to decide whether this is an urgent problem. And then we find that actually, in terms of clinical need, that's somewhat reduced. So what do we do about this, and what does the policy say about this? Well, many on the webinar will probably be familiar with the delivery plan for recovering access to primary care, which was launched a few weeks ago. I won't pretend that this has landed as an easy document across the entire of primary care and general practice. Clearly, it hasn't, and there are some complexities contained within it. But largely, it's predicated on tackling this 8 a.m. rush, the idea that as the shutters go up and the phone lines get switched on, there's a substantial upfront demand earlier in the day. And the idea behind this is that by undertaking a more detailed navigation, patients will be able to know on the day how their requests will be handled, and will find a compromise between clinical need and the patient's preferred consulting method. So this is necessarily going to require a lot more information to be offered up by the patients up front if we're to get this navigation correct. The idea is that this will empower patients. There's this commitment to busting bureaucracy again through this document, and a specific commitment to 26,000 more direct patient care staff to deliver 50 million more appointments by March of next year. That's, of course, 50 million more appointments from pre-COVID, of course, where we've already seen an increase in activity. So the key messages here are that the non-GP workforce are going to be a substantial component of this delivery, this access, and this busting this problem of 8 a.m. demand. And the general practice data set tells us several things. It tells us, for example, that between 1/4 and 1/5 of same-day demand is for musculoskeletal health problems, for example. And so it stands to reason that one particular group that has come under some interest as to the contribution they might be able to play in this is musculoskeletal health professionals, physiotherapists. And I'm really pleased to be able to hand over to my colleague, Professor Nicola Walsh, Professor of Musculoskeletal Health from the University of the West of England, to talk specifically about evaluating the role of first contact physios in general practice and this very issue. So Nicola, I'll hand over to you and give you control of the slides, and welcome to the webinar. Thank you.
Thank you very much, Matthew, and thank you everyone for the opportunity to speak about the Frontier study today on behalf of whole of the Frontier team. So first contact physios are located within primary care general practice, and their role is to assess, diagnose and manage patients with multiple musculoskeletal disorders. And all of this is without the need for prior GP consultation. Some FCPs within the role may also have injecting and prescribing capabilities, but this isn't a prerequisite to fulfill an FCP role. Within England, the long-term plan states that by next year, everyone within PCNs will have access to an FCP. And it's widely implemented across the whole of the UK. That implementation was very much driven by reducing GP numbers alongside those increasing demands for primary care appointments. So alongside assisting with GP workload, it was also thought the introduction of FCPs would expedite that access to expert musculoskeletal advice much earlier in the pathway, in the hope that this would improve patient outcomes, and also make better use of resource as it would free up GP time to see those more complex patients that they were managing alongside musculoskeletal disorders. So an overview of the Frontier study, it was a realist evaluation of effectiveness and costs. So realist studies look at what works, for whom, in what circumstances and how. And it did consist of 4 phases, but for the purposes of time today, I'm going to focus on the last phase, which was a mixed methods UK-wide evaluation of FCP models compared to GP-led models of care, with the aims of looking at how it may provide optimal patient management and show meaningful patient benefit, relieve GP workload pressure, promote better use of healthcare resource, and positively impact on the whole of the musculoskeletal system. So we had 424 participants that we followed up over 6 months at baseline, 3 months and 6 months post-consultation. And our work was divided into 3 arms. And it should be of note that these were models of care that were already implemented into GP practices. So we didn't impose a model, we just evaluated models that were already within practice. And those 3 models were FCP standard, so individuals who were expert physiotherapists but didn't have the additional capabilities of injection and prescribing. FCP AQ, so advanced qualifications, so they did have those additional capabilities to inject and prescribe, and GP-led models of care, so no FCP provision within the practice. Our primary outcome measure was the SF36 physical component score. There were multiple other secondary outcome measures, but again, for purposes of speed today, I'll just present those. We also had a health economics evaluation using the client service receipt inventory. And we also interviewed 80 patients and primary care staff as part of the evaluation. So the headline results, these are literally just available over the last couple of weeks and the first time that we're presenting these today. So the non-inferiority analysis showed that the primary outcome, the SF36, showed no significantly different outcome between the groups of either of the FCP-led models compared to the GP-led model of care at the 6-month primary endpoint. However, at the 3-month interim assessment, we did note that a significantly greater proportion of patients had improved, having seen either of the FCP models compared to the GP models. And that equated to about an 18% difference in the FCP arm and about a 12.5% difference in the FCP AQ arm. So a substantial proportion of patients improving quicker on the FCP-led arms. We also noted that higher proportions of patients were managed with opioid derivatives in the GP-led arm compared to the FCP-led models. And that was the same both with FCPs who could and couldn't prescribe. Of interest as well is patients in the FCP-led models of care had significantly fewer lost productivity days, so either off of work or able to resume their normal activities when they'd seen the FCP compared to the GP-led models of care. So some really positive findings to support that sort of FCP model. When we look at the impact on workload pressure, we could find no direct evidence to suggest that pressure is relieved. Waiting times for appointments were the same. And I guess we never really expected there to be a sudden reduction in GP use. And really what it showed was that it was just allowing GPs to see more complex patients. So what that was doing was obviously increasing the complexity of the caseloads that the GP was seeing. And that in itself was actually creating an additional burden. Some GPs were reporting much more difficulty, much more time required to see this caseload, when in fact some of the musculoskeletal patients were much simpler and easier to manage, but this had now been taken away. An additional burden was reportedly related to the larger teams that GPs were now managing, and the required mentorship to allow some FCP staff to actually achieve those additional competencies of injection and prescription as well. So some slightly more negative sort of results compared to the last slide. An interesting one, so promoting better use of healthcare resource. When we looked at the cost analysis associated with the cost of consultations and the subsequent research use, what we showed was that the median cost per patient who had seen a GP equated to about £105, whereas the FCP cost in the standard arm was £41 and £44 per patient median cost for the FCP AQ. So some obvious cost benefits there over that 6-month period. Interestingly, there was obviously no obvious benefits between having an FCP with those additional qualifications compared to those who weren't able to prescribe or inject as well. So whilst it provided a nice career progression for physiotherapists, actually as part of the FCP team, there are no obvious benefits that we can sort of note at the moment. However, what we can say is there's a clear cost minimization benefit of FCP models compared to GP models of care. So the headline results on the impact on the whole of the MSK system. This is something that we're going to need to consider really carefully going forward, because what we were seeing was a shift of physiotherapists from either community or secondary care-based services into primary care. And this was having an obvious impact on the provision of physiotherapy within other parts of the pathway. So some careful consideration needs to be considered as to how we manage that workforce across the whole of the pathway. And what we did note was the central provider provision, so the main provider of physiotherapy services, seemed to be a better model to ensure consistency across the system with physiotherapy provision. And what we also noted that whilst physiotherapists were there to do the first contact role, if they engaged in seeing patients maybe who happened to be second contact, who the GP had seen first and were referred over, or some problem patients who the GP had kind of not been able to manage successfully thus far, it was better for the whole of the musculoskeletal pathway process if there was some flexibility within that system. So in summary then, FCP provides a clinically effective, safe, and cost-beneficial model for people consulting with musculoskeletal disorders. Both of the FCP standard and additional qualification models provide equal benefits. So there's no apparent obvious benefit to FCPs having prescription and injection competencies at present. And going forward, we need to continue to monitor the impact on GP workload simply because of that shift in complexity and also their role in managing larger teams, and maybe some of the configuration around team management needs to be considered where other professionals may have non-medical kind of responsibilities for managing staff as well. So Thank you very much. I'd like to acknowledge all of my co-applicants on the study and all of those individuals that took part in the work, and also NIHR for funding the study. Just to note, I do have to leave a little bit early today, so if you have any questions specifically for me, please post those in the chat and I'll try to answer all of those. Thank you.
Thank you very much, Nicola, for that session and that overview of the first contact physiotherapy roles and the evaluation there. Clearly, it's complicated, and there are some benefits, some very clear benefits, actually, particularly in terms of perhaps the quality of clinical care, and maybe that may well persist long term as well and have some positive impacts further down the patient's care journey. But it clearly is complicated, and from what you've presented about the impact on workload, there are both intended and unintended consequences of these schemes, and it's important to bear that in mind when looking at implementing these moving forwards. That was an overview of a particular workforce group, physiotherapists, where perhaps the role is reasonably well understood in terms of how they, what their remit is, clinical remit is, the types of problems and patients they might be involved in. I'd like to turn to a colleague, Professor Sarah Voss, who's a Professor of Emergency Care at the University of the West of England, to feedback on a similar study, but this time a different professional group, paramedics. Now, paramedics, I think, have been an attractive proposition to primary care, particularly in terms of managing same-day demand due to the potential role that they have as generalist clinicians who see potentially all patients, undifferentiated problems, and how that might help manage the same-day acute demand. But I wonder if similarly we will see some complexities when this is looked at in more detail. So Sarah, I'm really pleased to welcome you to the webinar. Thank you for speaking on the Ready Paramedics project, and over to you.
Thanks, Matthew, for the introduction. And yeah, thank you very much for the opportunity to speak at this webinar today. So the study that I'm talking about is Ready Paramedics. It's also, like Frontier, a realist evaluation of paramedics working in general practice. And what we aim to do in the study is to look at the clinical and cost effectiveness of different models of paramedic working in general practice. So this work is not as far on as Nikki's work that we've just heard about. We have finished data collection and we are undergoing the analysis at the moment, but we are still analysing and interpreting the findings. So if you like today, what I'm giving you is a sort of sneak preview of what our early thoughts are. And just a reminder that this isn't for wider sharing at present. So Ready Paramedics is co-led by myself and by Matthew Booker. So it's a partnership between the University of the West of England and University of Bristol. We have a large team working on the project, providing their expertise, and it's funded by the National Institute for Health Research. So in terms of the data that we've collected for Ready Paramedics, we recruited 34 case study sites, which were GP surgeries across England. 24 of those case study sites had paramedics working within them. So those sites we've termed PGP sites. 9 of the 34 sites didn't have any paramedics, so are essentially non-paramedic sites. We wanted to classify some of the variation that's associated with different models of paramedics working in primary care, and we've classified each model in 2 ways. So firstly, we've classified them according to paramedic integration. And by this, we mean how well integrated the individual paramedic or paramedics are to the GP surgery that they're working at. So for example, some paramedics may be directly employed by the GP practice. They might work only at that site, get to know the team really well, the team get to know them, they understand their capabilities and their skills, they attend team meetings and all work together. And we'd class that as a highly integrated paramedic. Other paramedics are employed differently. They may be employed by the PCN and working in a satellite way across a number of different sites, perhaps for 1 or 2 sessions a week. So they're less well integrated to the team, and perhaps their role is not as well understood. So integration is classified as low, medium, and high for each site. And we've also classified them according to patient complexity. So by that, we mean what sort of patients are the paramedics seeing as the usual part of their job. So in some cases, this is low complexity, and the paramedics generally seeing same day cases, minor illness and injury, and kind of, just those lower complexity patients. In other cases, the paramedics have additional postgraduate skills, qualification and training, and they may specialize in certain groups such as frailty or asthma. And those paramedics are seeing more highly complex cases. And in some cases, the paramedics are operating very much as a GP would, seeing undifferentiated cases. So again, we classified each of the models according to complexity. And you can see from that table that we had a reasonable distribution across those models of classification. In terms of the data that we collected from our case study sites, it comes in 3 chunks, really. We carried out realist interviews with staff and patients. We collected quite a lot of data, 69 interviews in total. The vast majority of those were interviews with patients and staff from PGP sites. We collected a small amount of interview data from sites who didn't have a PGP, just so that we had some sort of comparisons to make. We also collected prospective patient data from all of the sites. So patients were recruited into the study and completed questionnaires to report on their outcomes, their healthcare resource use and their costs in the 30 days following their primary care index consultation, which was either led by a paramedic or a GP, depending on whether they had one or not. In that part of the study, we recruited 716 participants, and almost 500 of those returned their follow-up data at 30 days. And then the third component to the study is the retrospective patient data. So out of the 34 case study sites, 10 returned a data extraction from their medical records, which looked at healthcare resource use and NHS costs in the 30 days following the consultation, either led by a paramedic or a GP. And we had just over, well, 22,500 consultation index points. So in terms of findings, where have we got to with that? The qualitative findings are perhaps more well developed than the quantitative findings at this stage. And you can see that we've developed 6 broad theory areas that we're looking at the qualitative data in. Those are access, workforce, infrastructure, experience, outcomes, and safety. Now, improved access is almost universally accepted by the people we interviewed as a benefit of PGP. It's quite interesting, I think, that that is the case. And just to sort of give you more of a view of that, patients found that having rapid access to healthcare for reassurance, treatment, or onward referral, and the benefits of knowing that they will be seen mean that they view the paramedic service very favourably. And in pretty much all cases, patients find it acceptable to see a paramedic rather than a GP, particularly if they want to be seen on the same day. And for the practice, there were benefits to the improved access because the availability of additional appointment capacity eases the pressure on the practice staff. And it also means that they can delegate more specialised tasks and make better use of these skills. However, along with improved access, there are also likely to be some unintended consequences. So in terms of the workforce, the whole workforce needs to be able to adapt to accommodate the paramedic and understand their skill set. And also the caseload for other clinicians can sometimes change if the paramedic is seeing a particular patient group, and that has an impact on staff satisfaction and well-being. On the infrastructure, obviously additional resources are needed to accommodate the paramedic, and there are also wider system impacts, particularly if paramedics are leaving the ambulance service to take a job working in primary care. And in terms of patient experience, with improved access, there may be obviously improved experience for patients, but there's also a reduction in continuity of care for some patients, which is really important. And there's also a slight knock-on effect that even if the immediate access is better, so people are more able to access a same-day appointment, there may be subsequent waits. So if they see a non-prescribing paramedic, for example, they may have then a longer wait while the GP organises a prescription for them, or they may have to wait if the paramedic wants to consult with another member of the team to provide advice and plans for onward treatment. In terms of outcomes, along with improved access, in terms of potential for an increase, perhaps, in referrals, investigations, and prescriptions. And this was the feeling that many of the staff talked about, and something that we wanted to look into further in the quantitative data. Safety can be improved with better access to same-day appointments, but patient perceived safety might also decrease if they are seeing a member of staff that they believe doesn't have the same qualifications as a GP. So in terms of the quantitative findings, we didn't find any major difference in patient outcomes, although the data does suggest that patients at the PGP sites have slightly less confidence in their healthcare provision than those at non-PGP sites. The costs are quite interesting. We did some work to cost a GP consultation versus a paramedic consultation. It was quite tricky to work out how to do this, but our overall view on it is that paramedic consultations cost less in terms of the staffing, £14 compared to £21 for a GP consultation. However, when you take into account the healthcare costs, they look actually slightly higher in the PGP. And what's interesting here is that the costs we're showing here are excluding prescription costs. We've looked at prescription costs separately, and we're still trying to understand those. In our unadjusted data, there's an indication that prescription costs for patients who've seen a paramedic at their index appointment are considerably higher, perhaps almost double those who've seen a GP. We need to look into that and understand it more. And actually, it is possible that that finding does disappear when we adjust those findings based on other practice characteristics. So that's something that warrants further investigation. We've also had a look at the data according to the paramedic models that I mentioned earlier at the start of this talk. And what we're finding is that paramedics operating in a low complexity model have higher costs than those operating in medium complexity and high complexity models. A lot of that cost seems to be to do with referrals for ongoing care. And we're working hard to try and understand why that might be. One interpretation of it is that patients who have lower complexity conditions may warrant more referral because we need to understand what's going on for them. There's also the possibility that the paramedics working in those models have fewer postgraduate qualifications and training, and therefore rely more on the referrals. So yeah, that's just an overview provisionally of what we're looking at the moment. I haven't got any conclusion or summary to these slides because we're not really able to offer a conclusion or summary just yet. We're working hard on this. We're working on the final report, and we should be able to publicise the findings with a bit more conclusion later on this year. Thank you.
Thank you very much, Sarah, for summarising where that analysis is at the moment. And I think drawing the links with the Frontier project around first contact physiotherapy, there are clearly some expected implications and some work from the qualitative findings, which are perhaps not a surprise, but equally there's some bits emerging from the analysis which isn't quite as originally anticipated, and I think belies the fact that there are a mixture of intended and unintended consequences and some significant complexity behind implementing these models when it comes to managing access and demand and the consequences of that in primary care. Thank you. I'd like to turn to another colleague, Dr. Zoe Ankers, who is a research fellow at UE, to bring us the findings of an evaluation of the R scheme, the Additional Roles Reimbursement Scheme. I'm sure many colleagues will be familiar with this scheme and the aims behind it, but this is an opportunity for us to understand more broadly different professional groups and some non-immediate clinical initiatives in terms of providing better support to the primary care workforce. So Zoe, over to you, and look forward to hearing about the evaluation of the R's roles.
Thanks, Matthew. Good afternoon, everyone, and thanks very much for inviting me to present our evaluation study of R's, or Additional Roles Reimbursement Scheme. Nikki, who you heard from earlier, was funded by the NHS Insights Prioritisation Programme to conduct this research. There is some quant, but today I'm going to present the qualitative arm of this study. So as Matthew said earlier, and every one of us know here probably on the webinar, demand is greater than primary care capacity at the moment. The Additional Roles Reimbursement Scheme, or ARS, was introduced back in 2019 in primary care, and it aims to recruit 26,000 additional staff by 2024. Under the scheme, primary care networks are reimbursed for a cost for the range of roles. So the scheme is expected to impact the demand in primary care, expedite patient access, and also provides a career pathway for the roles under the scheme. So the funding of the scheme was due to end this year. However, it was announced just last month that a further 385 million has been made available to continue to grow ARS capacity. So currently there is limited evidence base on the effectiveness of the scheme, and what does exist presents a mixed picture about how best to establish these multidisciplinary teams in primary care. So the aim of this study, therefore, was to examine the implementation of the scheme, and in particular to identify its key enablers and challenges. So 15 roles now in total have been introduced under the scheme. They range from pharmacy techs to care coordinators. We've heard about FCPs and paramedics as well. Some of the roles have been established for longer, such as pharmacists, where others are still finding their feet, such as health and wellbeing coaches, and GP assistants and digital transformation leads only being very recently introduced at the end of last year, and advanced clinical practitioner nurses new for 2023-24. So we conducted a qualitative study. Participants were stakeholders related to the implementation of ARS from 3 geographical areas in southwest England. We interviewed 37 participants between July and November last year, and these included PCN leads, reps from training hubs, ICB workforce leads, those who actually recruit or place ARS staff, and of course a range of ARS funded staff themselves. So we analysed the data using framework analysis, and there were 9 categories of data revealed. I'm going to give you a whistle-stop tour of those today, and they're presented to you today in terms of whether they're enablers or they're challenges of the scheme. So let's start with the successes and the enablers of the scheme. So a key category that we identified was that staff are valued, but it was difficult to evaluate their impact. So most staff were feeling welcomed, they were feeling valued, they felt like they were making a difference, but the success of the roles perhaps isn't reducing GP burden specifically as yet anyway, but instead that the care offered in primary care is being broadened, with the skill mix that's coming in, increasing access to specialist care and appointments for patients. There were definitely circumstances where participants told us that our staff were saving GPs time and resources. However, again, it's still comparatively early days in the scheme. There's been a pandemic and the demand increases in primary care, all of which have made it difficult to tell how the roles have been helpful. This PCM manager sums up this perspective. I think our GPs are still massively worked. I suppose they do reflect how they would cope if they didn't have some of these roles. So another success was about how impact was maximised, and impact was maximised when using or placing the ARS roles in a specific way. So having multiple of a role made a real difference. And some have capitalised on this by creating a single service for staff across the PCNs for a particular role. Clear expectations from all parties about the scope of the ARS roles made implementation more successful. Some were really proactive about making sure their colleagues knew how their roles worked. They would give presentations, they'd meet new hires at PCNs or send out reminder emails. Also, reducing the risk of scope creep was important, particularly for staff coming in new to primary care, but with experience elsewhere. So this is a social prescribing link worker, and they explain we're not a nurse, we're not a doctor, we're not admin, and they don't really know where we fit in. So they were key to demystifying the vague roadmaps that came along with ours and the training pathways. So the ours roadmaps were overwhelming. They were delivered quite late in the process, so they came after many of the ours staff were employed. Many people described them that a great deal of time investment were required to complete them. And for some, it was a bit of a necessary evil, particularly those people with experience already. However, the training hubs in all three areas were crucial for demystifying the roadmaps and advocating in general for the implementation of the scheme. So moving on to the challenges that were revealed in our data, the one that I probably want to spend most of the time talking about was what we called scheme inflexibility. This category describes several inflexibilities that prevent the less wealthy PCNs, or those in more deprived areas, in making effective use of the scheme. So inflexibilities included unanticipated additional costs, largely for recruiting or retaining staff. So those are things like cost of living pay uplifts, supervision costs, estate costs, engagement of those third parties to actually recruit the staff, and also rigid salary scales that were limiting success when actually recruiting for the posts. Participants reported that if the full funding couldn't be used by a PCN, it was often reallocated to be bid for by PCNs which actually were able to use the funding. Another challenge was lack of supervision and career progression. So there was variation in what supervision was available between PCNs and practices. Supervision time is not funded under the scheme, and GPs and other professional staff just didn't have the capacity to provide it. We know it's important to ensure a sustainable pipeline of professionals to work in these ARS roles, particularly as we learned that some ARS role staff move roles or leave after completing their training pathway. And that was largely because of a lack of career progression opportunities. This PCN lead revealed this issue with pharmacists. You don't keep pharmacists for 2 minutes. As soon as they finish the pathway, they've gone. Infrastructure and integration. So both estates, office space and infrastructure, things like clinical equipment, digital technology, were lacking for our staff, and they just weren't anticipated by the scheme. People are doing their best and making it work, but it's a real challenge for many. We've seen it before in the literature, and yet it's still a problem at this time. Another challenge is integration into the teams. Working across multiple practices potentially increases the staff isolation. So this ARS staff member vented their frustration. I don't have a designated desk or a designated drawer or even a designated pen. So the final set of challenges we've grouped into unintended consequences, which had 2 points. The first one was the impact on the secondary systems. Staff are leaving secondary care, so such as ambulance trusts, hospital pharmacies, mental health organisations, community services, charities, to come and work in the ARS scheme, potentially with concerns leaving those secondary systems of an experienced workforce. These staff are attracted to the work-life balance, better working hours, no shift work was possibly mentioned by all of our ARS participants, and role variety in primary care. So rotation positions and secondments were both discussed as possible solutions to this. The other unintended consequence was impact on existing primary care staff. So some existing staff, not all, reflected that our staff were receiving better terms and conditions than themselves. Similarly, we learned that it was important to avoid de-skilling or sidelining existing primary care staff with expertise because of this wider skill mix coming in. So we've had the data analysis tied up, but we're at the point now where we are writing our rapid insight guides to help recommend implementation guidance of the scheme. And on this project, I did mention Quant at the beginning. We're collaborating with the University of Bristol on this project. Their team is very busily analysing quantitative data to explore the effectiveness of the scheme from that viewpoint. And they're looking at R's numbers, referral numbers, patients seen, and outcomes where possible. So when we see the outcome of that data, we intend to synthesize our results with that to give a more detailed picture of how the implementation of the scheme is working. So thank you very much. There's just some acknowledgements there, and I look forward to answering any questions you may have towards the end.
Thanks very much, Zoe, for that summary of the evaluation of the R's roles. And I think in keeping with previous themes, there is a lot in the detail of implementing these to make them work. There's a lot of interesting insights as to what some of the enablers for the systems might be in getting the best value out of R's and related initiatives. And I think to pair that, we've heard from 3 different presenters about particular workforce and perspectives of different workforce groups. It'd be nice to balance that with some perspectives from patients and the public, particularly given the emphasis in the primary care access recovery plan of patient empowerment and the need to provide more information to be navigated appropriately into the appropriate professional or workflow for the particular problem. So I'd like to hand over to a colleague, Dr. Helen Baxter, who is a knowledge mobilisation practitioner, who will introduce some public contributor colleagues and offer some perspectives from this side as well as to what we've been discussing. Thank you, Helen.
Thank you very much, Matthew. Hello, everyone. Lovely to be part of this webinar today. Today I'm joined by Jean Palmer and Sue Geary, who are 2 public contributors who've been working with me for some time on urgent care projects. And to give the patient perspective, and today we're just going to outline some of our recent discussions that we've been having in a sort of interview format to address some of the issues that have been raised in the presentations that you've just seen. So if I start off with the first question, as a patient, how do you feel about the navigation system described earlier in the session, where you may be navigated to see someone other than a GP when calling a primary care practice? So Jean, can I put that question to you first, please?
Certainly. As a patient, I'd be fairly confident to be navigated to the appropriate service at the right time in the right place. But I can understand it would be very different for different people who really feel that their problem is that urgent and they really do need to speak to a GP when nobody else will be suitable for them to speak to. I think you've got to have a certain trust in the navigators that they're going to send you to the right place, and that if there was something they were unsure of, they could refer to somebody else. And unfortunately, historically, this isn't a role of a receptionist, and the navigator is different from the receptionist, and the receptionists in the past have got, had difficult relationships with some of the patients, and this is why we need education into what actually is going to happen.
That's great. Thank you very much, Jean. And Sue, could I ask you for any reflections?
Yeah, thanks, Helen. On the whole, I think I would be quite happy to be navigated to a different professional. The only thing I would be slightly wary, well, 2 things I'd be slightly wary about. One is I manage a long-term condition for myself, and I'm lucky enough to have a GP who knows me and my condition. So if I felt that urgent issue was related to that condition, it goes back to that issue of continuity of care. I might prefer to see my GP who understands my particular condition. So that's one thing. And then leading on from that, I think my only other concern would be about talking to a navigator and having to explain my story several times over in order to get to the right person. So it's that repetition of my symptoms or my problem and my background in order to get the treatment that I feel I might need.
That's great. Thank you, Sue. Thank you, Jean. If we move on to the next question, which healthcare professionals other than a GP do you feel you might be able to help you with your problem within primary care? Jean, if you could first, thank you.
I feel that that there's so many different roles, as has been highlighted today in the webinar, and really as a patient, you know, there's not enough information about what the different professionals do, or so that you could perhaps make an informed choice on would that be a suitable person for you to go and see. So, you know, it really does need us public to be informed about what a service our GP practice offers and the different healthcare professionals available within that practice.
That's great. Thanks, Jean. Sue, any further comments?
Yeah, I think I agree totally with Jean that I don't think we as patients know enough about the different roles of different people who work within primary care and what they could offer. And a good example might be if I feel I need a prescription for something, I don't know who other than my GP is able to prescribe, and if they can access a prescription by talking to a GP. So I think it does require us to understand the system a bit better in order to have that trust.
Great, thank you. And our last question today, and I'm going to put it to you first, Sue. Do you feel that in all cases, seeing a GP would be the patient's choice, or do you feel other professionals may have other skills and perspectives to offer? Sue.
Yeah, I think it's almost the other way around. I'm sure the other professionals do have lots of other skills and perspectives to offer, but I do still think that some patients think that seeing a GP is like the gold standard. And if they don't see the GP, then anything else is just a replacement for that role, despite what they could offer, and even if the outcomes might be better.
And Jean, anything further to add?
Yes, I think you know that every patients realise the NHS is under a great deal of pressure in all systems at the moment, and I think if the public understood, the patients understood, you know, the choice of healthcare professionals and what they could actually help them with, you know, I think they'd be more willing to accept, you know, a consultation with them.
That's great. Thank you both for your reflections on that. That's been really great. And now I'm going to hand back to Matthew to sum up.
Thanks very much, Helen, and thank you, Jean and Sue, for those reflections. And I think what's really interesting from those responses is that we've heard a lot about how these different roles have challenges in implementation from the practice and the system side. Equally, there are clearly challenges in explaining how each of these roles function, how the patient experience might be in some ways better if patients have contact with these different roles, and where that's appropriately placed in the bigger scheme of things. And I think there's a lot of work for us as healthcare professionals and academics to do in understanding how best to communicate those messages about where those roles are best placed, and when you see them, what's likely to be the outcome from that. So I think that's really interesting to hear the other side of the story, and I'm grateful for those reflections. We have a couple of minutes, we have about 5 minutes remaining, and we have the opportunity for some questions and answers to various different contributors who are involved here. I have a couple of questions through, and there's also one in the chat. I'd like to start with a question if I may, that's in the chat, which I think, if at all possible, I might ask Sarah Voss if you might consider responding to this one first, if you have a view on this. So the question is, what do you think about how we begin to train up the workforce? Should undergraduate programs include advanced practice placements, etc.? And I think I'm thinking particularly of some of the sort of findings from the work about training the paramedic workforce that you might be able to speak of here.
Yeah, thanks, Matthew, and thanks for that question. Yes, I think it's interesting, and we do need to make sure that staff are well trained and well prepared to go into these roles. I think there's a lot of work going on at the moment with Health Education England, and the College of Paramedics, working on ways to prepare paramedics, particularly for jobs in primary care. I think one of the tricky things is that we don't really quite understand what is needed because of the variation in the roles that they perform. So it depends, I think, what practices are actually looking for in terms of which paramedics they employ, whether they want somebody who can, be more generalist and see and differentiate patients, or whether they're looking for something slightly more specialist. So I think we're still in the early stages, really, of understanding what's needed in terms of training. And also, just trying to understand what the comparative contribution of the different roles are and where best to focus our efforts.
Thanks, Sarah. Yeah, I think it's a challenging one, getting the education right at the right level and at the right point in people's careers as well. It's a really difficult, finding a difficult balance. There's another question in the chat, which I think it is worth spending a couple of minutes addressing, because it's a really important one. And Zoe, you might have some initial thoughts on this one, and then Helen, I might come to you to see if there's any further thoughts from yourself or our public contributors. Are there any findings from the work so far, or reflections on how these strategies may impact on inequalities? Zoe, I know you had some thoughts about how representative some of the work so far has been in terms of the potential issues around inequalities. Do you have any thoughts on a response to that one at all?
Yeah, I think probably Sarah and Nikki's gone, but they might talk about their data sets and how potentially some of them were skewed. But in terms of answering that question from the qualitative study that I presented on, the concerns that we had about one of the challenges was scheme and flexibility. So initially, at least from a qualitative point of view, there are concerns there that there potentially are inequalities with certain areas potentially having more access to Rs roles than other areas. We are waiting to hear if that's being confirmed in the quantitative research. So they do have data on that. And so we are very keen to hear if that is reflected in the quant as well. Are more Rs roles being distributed in wealthier areas? Are there less in areas of deprivation? So in terms of the Rs roles per se, there is a concern, at least from the qualitative, that the strategies at the moment under the scheme is that potentially that could be leading to inequalities there. Sarah might be able to answer that a bit more from the paramedic workforce.
Thanks, Zoe. I think I have little really to add to that. I think it's an interesting opportunity. Services are very much set up based on their local need. So services that are set up in more deprived areas often have a slightly different model of operation. And I think it's something that in research we need to work harder to address to properly investigate that.
Thanks, Sarah. And Helen, just in the last sort of 30 seconds, I don't know whether you had any thoughts additional to that, something you've discussed with the public contributors.
I think it's a really important question and one we just don't know enough about. I think that is a real area for exploration, and to make sure that we are addressing that and that the additional roles becomes an opportunity to reduce inequalities. So I think that's an important area to understand more about.
Certainly some targeted work probably needed.
Yeah, I think so. Very important.
Thank you. Well, we've come to the end of our time. I'm really grateful for all of the contributions from the panel members and from our public contributors. I think we've covered a lot of material and some really interesting findings from work that's just coming towards the conclusion point. So thank you, everybody, for your involvement. I'm going to hand back to Helen Bolton just to close the session now, and thank you, everybody, again for joining.
Thanks very much, Matthew. Yeah, and thanks everybody for sticking with us till the end. I'm just going to pop up a last little slide. Just bear with me a moment. Yeah, so hopefully you can see that now. Yeah, so just to say thanks to our speakers, all of our speakers, especially our public contributor speakers, Jean and Sue, for a very interesting and very topical and current discussion. If you would like to keep in touch with us, there are a number of ways of doing so on the slide here. We will be sharing with you a recording of the session and the slide set also. So we'll send you a link to those. It will be within the next week or so. The next webinar in our series, we haven't firmed up all of the details. So for the moment, I'll just say it will be in September, and it's going to be hosted by our Domestic and Sexual Violence and Health Research Group. So please keep in touch and keep an eye out for notice about that. We'll be announcing the details shortly. Right, so thanks very much, everybody, and I hope you all have a very good day.